time it is. Marvin Devine, Huber, Axel, and you know how we do. Yeah, I got the juice. Whip game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing that. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, just wanna get in my crew, but you can't get in my crew. Me, Axel, and Huber way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we link up. Let's go. Yeah, I got
Here we go, here we go, here we go. Go to YouTube or Facebook, you need to get search. Support the show. Good evening, and good afternoon, wherever you're watching from. Welcome to another broadcast of Kidney Hub East Africa. I am half your host, Steve Belcher. Let's see, we've been having some technical difficulties with our other host, the kidney ambassador, Moses Kennedy. Let's see if we can get connected with our brother in Nairobi, Kenya. Hello, Brother Moses.
How are you, Steve?
You there? Hey, man, what's going on?
I am.
The audience wants to know what's going on with your connection.
My gadgets are failing, but let's try it out.
Okay. We had a crowd that was waving to you from TikTok. And so I was telling you to wave at the crowd.
It's my gadget.
Okay. Okay. All right. So how's it going, brother?
I'm good. I'm doing great.
Okay.
I'm just traveling back from Nairobi.
Okay.
I'm in Kisumu
just
at the
traveling
moment.
back from Nairobi.
Yes.
How
Yes.
How far do you live from Nairobi?
Yes.
How many miles are you from Nairobi? We have a broadcast delay. How many miles are you from Nairobi?
Hello, Brother Steve. Can you hear me?
Yes.
Oh my God. It's
Moses, how many miles do you live from Nairobi? All right. Again, we're having technical issues with Brother Moses. So let's move on with the show, what we're here for. And we're here for how to care for your dialysis access. Especially this show is for our brothers and sisters in East Africa, if you're watching, okay? And for our brothers and sisters in the United States who just started kidney dialysis. You have a family member, a loved one, and you may have a catheter, you know, a hemodialysis catheter that's in your neck, could be in your groin, or maybe you got a fistula or a graft in your upper or your lower arm, or maybe you have it in your leg. Either or, vascular access, let me repeat this, vascular access is one of the most critical elements, one of the most critical elements of successful dialysis care. If you don't have no dialysis access, you don't get no dialysis. Say if you got an access in your arm and it gets infected, then they're going to have to put a catheter inside you. So vascular access, again, is one of the most critical elements of a successful dialysis. Now we're going to try Brother Moses one more time. If he can't stick around, we're going to have to put him in the corner so we can move on. Brother Moses, can you hear me? Brother Moses, can you hear me? All right, I'm just going to let you sit there. So, as I was saying, your vascular access is one of the most critical. Brother Moses, Brother Moses, I got to go on with the lesson.
Christian.
I got to go on with the lesson, Brother Moses, because you keep going in and out. Okay? So again, the vascular access, whether it's in your arm, your leg, or you have a catheter, is one of the most critical elements of any successful dialysis. However, since fistulas work better than any type of access, you're like, what, Steve? What do you mean fistulas work better than any type access? Yes, your own vein, which is the fistula, which is the artery and vein sewn together to create one large vein, is referred to an arterial venous fistula. Okay? And fistulas work better than any other access because it's using your own natural vein. You're like, what do you mean, Steve? What about the catheter? What about the graft? Well, the graft is a man-made device, just like the catheter is man-made. And so anything pretty much man-made, you're not going to get the type of cleaning that you would get with your natural veins. Okay? Now, look, a lot of guys be wondering when they go into dialysis after they just started, you know, I don't know how they do it over in East Africa because it's different because they don't have Medicare. But let's just say if they did. A lot of people don't know here in the States that Medicare, see, the clinics know, that's why they try to persuade you to go and get the catheter removed and get the surgery when you know mentally you're not ready to do it. Because Medicare has set goals. They set goals for kidney doctors and dialysis providers to increase not decrease, increase the number of patients using this type of vascular access. And how do they do that? They hang incentives over their head. So that's why when you start dialysis, you haven't even been there a week. You haven't been there 1 week. Next thing you know, you sitting down, you got your headphones on, you watching TV, and someone comes to your chair, tap you on your arm, and you turn the TV down, remove your headphones, and they be like, Mr. So-and-so, Miss So-and-so, we made an appointment for you at the surgeon. And you're like, huh? What surgeon? I don't know those. I don't know the surgeon. How you gonna pick a surgeon for me? Shouldn't I be able to do that? Do my own research? What if I go in and that surgeon's trash? Just like maybe butcher my arm up. They tap you on, here you go the appointment. And most patients go along with it. They take it, and they go to the surgeon, and really, it's a consult. That's all it is. It's a consult. Moses, can you hear me? So it's just a consult. You don't have to agree. You just listening to what they're saying. And next thing you know, they do the Doppler, they check your veins out. And then they set you for surgery. Next thing you know, like, what happened? You don't have to do that right away if you don't want to. So if you just started dialysis and you got the catheter, yes, you are prone to infection. But if you know you're not touching it, and the people at the clinic are the one handling it, who is more likely to give you the infection? Not you. It's the people who's handling it. Are they washing their hands? Are they changing their gloves? Are they putting their mask over their face, over their nose? Because we know right here in the nasal flares, people have staph. Very harmless. That's why when you go to the hospital, they check you for MRSA. They swab your nose. And that's why we had the staff put the mask over their face. So they're trying to make improvements in vascular access. They want everyone to work as a team, the clinic, the doctors, to persuade you to get a fistula when you may not be ready. But the access is definitely the critical element of any successful dialysis. So let's talk about the different types of dialysis access. Okay. You got the fistula. And this is what this is right here on TikTok as my background. And a fistula, as I said before, is a natural type of vascular access where your own vein is surgically connected to an artery. The increased blood flow that results from this connection causes the vein to enlarge and the vein walls to strengthen. Now, because the fistula is placed completely under the skin, some of them could be deep. It's called an internal vascular access. And so needles must be used to access the bloodstream for dialysis. And you may say, Steve, what type of needles are you talking about? Let me show you. Talking about needles such as this. Okay? These are 15 gauge, 1-inch needles that are mainly used for dialysis. Now you got other sizes. You got your 16, you got your 17. Let's see if we can get our brother back on again. I mean, I hate to keep interrupting the lesson, but he fell off. So, okay. Needles, as I just showed you, right, must be used to access the bloodstream. Now they're using 2 needles, one for the artery and one for the venous. And the arterial brings the blood out of the body or in the dirty blood, and it goes through the filter, and the clean blood comes back into the venous needle, the top needle. So you need 2 needles when you're using a graft or a fistula. Now, overall, the fistula is the preferred vascular access for hemodialysis because of its low complication rate. However, you can have complications like when they create a fistula, and if you got small veins, especially if they create it here in the lower forearm, and if it doesn't completely develop and they're trying to stick you, somebody can easily infiltrate you. One nick of the access wall can cause that blood to come gushing out and cause you to swell up. See, that's what it is, the hematoma. If you ever been infiltrated, like, Steve, what's infiltration? Oh, infiltration is infiltrating, going through your access wall, whether it's a graft or fistula, with the needle. These needles are sharp. Make no mistakes. These needles are very sharp. And one nick, that's why you got it. When you stick in a patient, you can't go in shaking the needle, being nervous. You got to know what you're doing. You have to do it with care and consideration. Because nobody wants to be stuck with these needles. Now let's talk about the second type of vascular access. And that's the graft. And that's something like a flimsy tubing, not like this, but in a way similar. And it could be in, they could put it in, and it could be shaped like a horseshoe, be right here on the arm, under the skin. One end connects to the vein, one end connects to the artery. and you stick a needle in it, 2 needles. Now, a graft is a synthetic tubing. It's synthetic, surgically connected to your blood vessels. Now, if I can show you in this diagram right here, this is a graft under the skin. Just like the fistula, it is placed completely under the skin and therefore is called an internal vascular access. Again, needles must be used to access the bloodstream for hemodialysis. Because a graft is made of artificial materials, it is more likely to develop complications and does not generally last as long as fistulas. So what am I saying? The graft is made from artificial material. Because of that, because it's made from artificial material, it's more likely to have complications and not last long than the fistula. That's why they want people to get fistulas, but not everybody can get a fistula because size of your veins. Now, when you get this graft, you be like, Steve, what complications are you talking about? Share it with us. Complications I'm talking about, 1, infection. You say, wait a minute, how can I get an infection if the access is under my skin? Good question. Again, we have to stick the needles through your skin to get to the access. We all have germs on our skin. And if you have an internal access, it behooves you to wash your access twice a day with antimicrobial soap. Twice a day. And then when you go to dialysis, it behooves you to utilize and take advantage of the sink if your clinic has a sink used for patients to wash their access. Because one thing for certain and 2 things for sure, when you go sit down, you don't know how many alcohol pads that technician may use to wipe your access. They may just use 1 and go up and down. And that's not really cleaning your access. And then if you still got germs left on the surface where they're going to stick the needles, now they're going to introduce a needle into your blood vessels where germs can sneakily get in. And artificial material does not like bacteria. And next thing you know, you start seeing redness, swelling. maybe even pus discharge. You may wake up and you see like, what's going on? Next thing you know, you're starting to have a fever. You start getting chills. And that's when you call the dialysis unit. Hey, this is what's going on. Go to the ER right away. Even if you're in East Africa, if you got a graft and you wake up and you see discharge, redness, you got chills, we know the communication system is different over in East Africa, but you go to the nearest hospital right away. We got our brother back again. Let's see if he can add to the conversation. Brother Moses, are you with us?
I'm fine, Steve.
Okay. So Moses, Brother Moses, I'm sitting here talking about access, and right now we're talking about a graft. What type of access do you have? Share with the audience.
I currently I'm using a fistula, chest catheter, but I've tried a fistula twice. It failed. So at the moment, I'm using catheter, chest catheter.
Okay. So your fistula failed. Did they tell you why? Do you have small veins?
Oh, yes. They talked of having some small veins, but I also wanted other option like graft. But then it was unfortunate that we don't have surgeons that can place that graft. So I had to understand and to get used to what is available. Chest catheter.
Okay. So how long have you had your chest catheter?
I've had it the longest ever since I started dialysis in 2017. And I've only had twice infection. Thrice, but I'm very sure it was never on my side. Perhaps it was on the dialysis technicians. I know where you are, catheter are not used that so much. Some of us watching will be shocked. But it is a common place in Kenya to overstay with your catheter.
Really?
Because it is mostly available. Going for fistula will mean bookings, doctor's appointment, and consultation fee and other extra cost.
Okay.
Yes.
Okay. So, Brother Moses, so people probably want to know what we're talking about. You have what's called a catheter, or also known as a central venous catheter, or CVC. And that, let me get an example to show the audience what we're talking about. So this is what we're talking about right here. Okay. Mm-hmm. This is what you have, correct?
Yes.
Okay.
That is what I have. Yes, that is what I have.
And you're saying a lot of our brothers and sisters over in East Africa have the catheter.
The catheter. because maybe the failure rate for fistula fixation is so high. I don't know why it's so high. It's so high that they try to fix you, whether you have a good vein or not. Failure rate is still very high.
Okay, okay. So let's
I
talk
don't.
about let's. I'm sorry.
I do not know how about over there in the United States. Catheter used for that long, for longer time, like maybe 3 years, 4 years,
Yes,
because mine
there's
have
some.
used it for
There
6
are
years.
yes, there are patients here that use it for that long because they don't have any place else to go.
All right.
Mhm. Yeah. So let's talk about this for a moment, okay? Um, this CVC or tube-like device, this is inserted into a large vein, usually in the neck or the groin, because two small tubes uh, with caps permanently lie on the outside. These got caps right here, as you can see. They hang on the outside of a person. So when you see this, you're just seeing this part right here. You're not seeing the tube that goes into the vein and into the back of the heart. Um, Now, because it lies outside the body and the catheter is implanted, it's called an external vascular access. And the remainder of the catheter, the part you don't see, which is this travels under the skin and into a vein. Ultimately, the internal end of the catheter rests in the top chamber, of the heart. And so, in order to access the bloodstream for dialysis, the two outside tubes are connected to the dialysis machine. Because so much of the catheter resides on the outside of the body, it is exposed to many more risks, including infection. Now, Moses, have you ever experienced a catheter infection?
Oh yes, it is one of my worst experience, and
Tell us
it is
about it.
normally it is marked and cold, and you just become terribly sick all of a sudden, especially if you have an infection. The moment you get into dialysis chair and maybe you begin your dialysis for 30 minutes, the chills just come knocking. I tell you, Steve, it is terrible, terrible chills. And all of a sudden, you become sick. Mm.
And what else? I mean, have you ever went to the hospital for this, Moses? Tell us about it. Moses, can you hear us? Brother Moses, can you hear me?
I know in most cases, if you are not taking action immediately, then it means hospitalization.
Okay. And how do they treat your infection, Brother Moses? How do they treat your infection? So till we can get, again, we're having technical difficulties live from Kenya. That could be expected because of the internet service over there. But listen, let me see right quick. Brother Moses, can you hear me? Brother Moses, can you hear me?
I can't hear you.
Sign out and sign back in.
I don't know whether it's on my end.
No, it's on your end. Moses, can you hear me? So until we get that straight, we're going to move on. So as I was mentioning, Brother Moses has a catheter like this. And he was mentioning that he experienced many infections. And normally, like he said, as soon as you realize that you have an infection, maybe chills, fevers, redness around the catheter site, pus discharge, right? From the outside of the exit site, you want to take action immediately so you can get antibiotics. Some patients, if it's a catheter infection, because again, this is man-made. This is man-made. And if bacteria or germs get on this and cause an infection, you're going to have to get it pulled out. And now you don't have any access for dialysis. None at all. So let's add Brother Moses one more time. Brother Moses, can you hear us? Again, the internet service over in East Africa is really, you said I'm frozen on TikTok? Hopefully I'll come back. Thank you, Lachey, for coming over. I appreciate you. Let me see. Hello. I still see people coming in on TikTok. So thank you for letting me know that. Brother Moses, can you hear us? See, he just got kicked out. This is unfortunate because Brother Moses has a lot of information to share from Kenya that can be helpful here and can be helpful over there to let you know how fortunate a lot of kidney patients here have it when it comes to dialysis. Over there, they're only allowed to get dialysis twice a week. Now, can you imagine only having to get dialysis twice a week compared to 3 times a week? But they can't get 3 times a week unless they come out of the pocket. So, as I was saying, with this catheter, because it is out on the outside, exposed to many risks associated with that infection. It can get snagged out. I had patient come in and the catheter was hanging down to her stomach. And the dressing was on it. And we took the dressing off, the catheter popped off. No blood. A lot of people think the catheter come out, a lot of blood. That's not the case. It seals up. But it can happen. But for most part, it comes out, patient, they bring it in, hold it. My catheter came out. Now they don't have an access for dialysis. You're like, how can it come out? Because you could be in your sleep, you could tug on it, whether how you sleeping, maybe the stitch came off. So they say that it can potentially lead to many complications and is therefore intended to serve only as short-term vascular access. So technically, they made these to last short-term. They didn't expect people to have small veins. Your veins don't work. So now you got people like Moses having them in for years, 4, 5, 6 years. So if they have over there, if they be having their catheters in for that long, that ought to debunk what people tell you when you coming new to the clinic and they tell you you can't have this in for a long period of time. He's like, no. I was listening to Steve, the kidney nurse, and it was a guy from Kenya named Brother Moses, the kidney ambassador. And he's been having his in for years because his fistula didn't develop. So don't let them, again, as I say, guilt trip you into getting the access when you're not ready for it. So the next step, that's a good question. We had a question from Alicia Richmond from YouTube as what is the next step after it comes out and what is the answer for small veins? Now, after it comes out, you call the surgeon. No, most likely they're going to tell you to even go to that. You call the unit, let them know. They'll set up an appointment either at the access center for catheter insertion. You just get another one put in. And with the small veins, depending on what's the cause, it could be PAD, peripheral artery disease. PVD, peripheral vascular disease from diabetes, or peripheral artery disease, PAD. So the answer to that question, what's the answer to small veins? A lot of times they try to stretch the veins, put a stent to make it wider. They do all these surgeries. Then next thing you know, they go up to another place, thus leaving your other area traumatized. Now you probably can't feel feelings in your fingertips, can barely hold water bottle or cup. At dialysis, soon as you get on, your arm is aching. So, hold on, guys. All right. Who knows? So, yeah, this is in real time. You had things that happen. I wish I could be in a professional studio and have technical guys helping me out here and broadcasting this. But this is live. This is a lot of people I don't remember. This is live, not Memorex. So people are like, what's Memorex? You got to look that up. You're not from that era. But technically, the catheter, and if you're in East Africa watching this is only supposed to be used for short term. And they get, when they're ready to do your surgery, and once that's finished, and they start sticking you, and they have successful, we call it cannulation or sticks, then they remove the catheter. But if they start to have trouble, they're going to leave this in. Because if you get infiltrated in your arm and it's new, and you still got your catheter, then we can use the catheter and let the arm rest. That's why a lot of patients, when they get new accesses placed in, they may not, no, I'm not ready yet. Use the catheter. Because they know they still got the catheter. They may not be ready. I'll probably be the same way. They may not be ready to get stuck with these large gauge needles. So we leave this in until we successively had 3 cannulations or 3 successful sticks. Then they get on the phone and call the surgeon. We want to make an appointment to have the catheter removed. A lot of patients be happy to get this out. I would too. Who would want something like this? And see, this is not soft. This tube right here, this is kind of hard. So can you imagine this going under in your vein, and you see a piece, and it's like, damn, it just doesn't feel right. So that's why they address kidney patients as warriors. All right. So let's talk about physical assessment of your vascular access. All right. Your access allows you to receive life-saving dialysis treatments. And because of this, it is commonly referred to, and a lot of warriors know this in the United States, as your lifeline. A well-functioning access is necessary to achieve maximum dialysis efficiency. I'm like, wait a minute, Steve, what the hell are you talking about? Maximum dialysis efficiency. Yes, that's what we mean when they do the monthly labs and they ask you, what's your KT over V, your URR, the urine reduction rate. The KT over V looks at, are you getting a quality dialysis treatment? Are we clearing the waste out of your blood? And the access, your access is very much a part of that equation, just like the filter, the artificial dialyzer, the blood pump speed. All of these components, if your access not working like it should, you're not getting a good quality dialysis because the blood comes out of there. If they got your blood pump not at the rate that your doctor set for at 450 and you're running at 300, and if you don't know that your blood flow rate is supposed to be at 450, how would you know any different if you see 300? You got somebody new or people who don't know you working. You see it all the time coming to clinic to clinic. They're not looking at your orders correctly. And it's lab day, and they got your blood flow rate at 300. and it's supposed to be 450. And you get your blood work back, and your KT over V drop. You're like, wait a minute, what the hell happened? And you can't figure it out. It won't never get figured out because no one knew or remembered that your blood flow rate was at 300. So that's why it's very important to know what your dialysis orders are if you on dialysis or you got a loved one. Had a patient the other day getting ready to get the medicine and said, this is your iron I'm about to give you. They asked me, is it 100 milligrams? I said, yes. Hold on. So, now, when the dialysis treatments become inefficient, you're not getting a good quality treatment, or inadequate, that means toxins accumulate in the body. Even while you're doing dialysis, you wonder, wait a minute, dialysis is supposed to clean my blood. Why are these toxins still in my body? What's going on with your access? And when the toxins start accumulating in your body and you're getting dialysis, this could potentially impact the quality of your life. What I mean by that? Man, like why I'm always itching? Why my skin always dry? Why I always feel nauseous? Why I'm always tired? Why I can't sleep? Why my legs restless? All this can impact the quality of your life. So by paying attention to the health of your access, your dialysis access, and making sure problems with it are fixed right away. Don't hesitate. I mean, right away. Your access will last longer. Like I said, the average length or use of a graft, that's the man-made, is about 5 or 6 years. If you get more than that, you're considered blessed. Because imagine having a graft made out of that material and you poking it 3 times a week, twice for 5 years with the needle. Nothing lasts forever. So that's why you want to make sure you're washing your arm with the antimicrobial soap. When they stick you, they rotating the sites and not sticking at the same area. That they cleaning your arm with the Excel or multiple alcohol wipes, and they using the rotation, the inner rotation method. And what does that mean? Because they're bringing the germs away from where you're going to stick, inner, outer. This is how you keep your access working longer and reducing problems. So changes within your access are oftentimes subtle. When you start getting changes, you won't even realize it. And it could take weeks, even months to develop. So because it is, they say it's important to evaluate your access every day. And that's true. When you wake up, look, listen, and feel. And we're going to talk about that method, to look, listen, and feel. Because you are in the best position to notice the changes in your access. Not me, not the nurse at your clinic or the technician, but you. Because it's your access. So you want to check it twice a day to prevent complications in the future or before they evolve. So I talked about the look, listen, and feel if you got an internal access, like a graft or a fistula. So let's start with step one, look. You say, Steve, what we looking for? What we looking for, Steve? You're inspecting the skin over your access. And you're going to look for changes in skin color, swelling, redness, and enlarging bumps. It's not normal. It's not normal. Allow scabs from your previous site, is going to scab over. Allow scabs over previous sticks to completely heal. Don't disrupt them or go in the same spot you went last time if it's a scab there. That's another way of introducing germs or infecting your access. After you look for changes over your access, the changes in skin color, swelling, redness, enlarging bumps. Again, that's not normal. Number two, feel. Run your hand. Run your hand gently across your access. Okay? You will feel a distinct buzzing feeling known as a thrill. Starting at the incision line where they cut, and you'll see it even down at the bottom of your wrist or right here, crease of your arm. Starting at the incision line where the artery and vein are connected to form your access, run your hand across the entire length of the access. The thrill should be strongest at the incision line, also called the anastomosis. And should gradually fade as you move your head to access. Now, if you have a fistula, it should feel soft and can be compressed easily. And if you have a graft, it will feel firm, like a tube. Now, check this out. A strong pulse in the fistula or graft without a gentle thrill is not normal. So if you have a strong pulse, but you can't feel anything, that's not normal, and it may be clotted. So let's talk about step 3 of physical assessment of your vascular access. Listen. You say, what do you mean listen, Steve? Listening to your access and knowing the meaning of the sounds you hear can help detect common complications. Now, we recommend using a stethoscope that you can get from Amazon or any medical supply store. Okay? And if you can't get one of them, you can use your ear. It's like, how I use my ear? So if your access is down here, you put it up to your ear. If you got a stethoscope, you put the bell, that small spot where they listen to your heart, you put that over the site. And so when you're listening to a fistula or graft, you will hear a whooshing sound called a bruit, like whoosh, whoosh, whoosh. A normal bruit will be low pitched and continuous. So begin listening at the incision line and moving up the entire length of the access. The bruit should be strongest at the incision line and should gradually fade as you move up the arm listening. Again, if no stethoscope is available, you can position your ear over your access to determine if the flow sound is present. So, I don't know if our warriors over in East Africa have access to a stethoscope. And let me show you how one looks like. This is a stethoscope right here. It doesn't have to be all fancy like this. Just one where you can put in your ear and listen to your access each morning and before you go to bed. And make sure you wipe the bell with alcohol. Now, I'm going to we're talking about a couple of complications pertaining to vascular accesses. I'll probably quickly run through this. One complication of the access, graft, or fistula is called stenosis. We got a lot of people got to go to access center, get what's called a fistulogram because of this, stenosis. Go to the access center to get a fistulogram for that. Put it in the comments. TikTok or YouTube or Facebook. You know what I'm talking about. So we say, Steve, what's a stenosis? A stenosis is a narrowing inside a fistula or graft that restricts blood flow through the access. So if it's a narrowing in your access, blood can't move through it. And that's why you clot. Because if blood can't move through, it stays stagnant or still. And then you clot. There are several warning signs that may indicate that a stenosis is present. During your dialysis treatment, a stenosis can cause arterial or venous pressure alarms. So be aware of these alarms, what they mean and how often they ring. That's why I say, know what your baseline arterial venous pressures are coming from your arm. A stenosis can also extend the length of time that you must apply pressure to the needle site after dialysis. So let me repeat that. A stenosis can also extend the length of time that you must apply pressure or hold your site to the needle sites after dialysis to control the bleeding. So if you've been holding your venous for about an hour, 2 hours, like, damn, I've been here a long time. It could be a stenosis developing above that area, causing the pressure. So be aware of increased bleeding times or bleeding that restarts after it has stopped. Difficulty with needle placement may result from access stenosis. So be aware of changes in the level of discomfort you experience when the needles, the dialysis needles, are inserted and removed. Your bruit and thrill will be affected by a stenosis. Perform the access evaluation daily. Be aware of changes in the whooshing sound of your bruit and the buzzing feeling of your thrill. If left untreated, a stenosis can evolve into a thrombosis. Let me remove this because I am not Moses Kennedy. If left untreated, a stenosis can evolve into a thrombosis. Like, Steve, what is a thrombosis? Well, I'm going to tell you what a thrombosis is. A thrombosis is a formation of a blood clot inside of a fistula or graft that completely obstructs blood flow through the access. So a thrombosis is formation of a blood clot inside a fistula that completely, however you want to say it, obstruct, block the blood flow through the access. So no blood can go through it. So it stopped working. A loss of bruit and thrill are key signs that the access may be clotted. So if you don't hear the whooshing sound or feel the thrill, 9 times out of 10 you're clotted. So that's why we tell you to check it twice a day, because if you don't feel that and you're at home, it saves you time from going to the dialysis clinic. You waiting to go in. Then when you get in, if the technician doesn't do the look, listen, and feel and determines, they may just automatically, just by nature, clean your arm and try to stick you. And next thing you know, you see this dark blood coming out here and nothing moving. You're like, what's going on? Then they pour the needle, call the charge nurse. Hey, Becky, so-and-so, I think clotted. Can you come listen to it? You're like, huh? And here come Becky. Hey, you causing me trouble today, Mr. Smith or Mrs. Smith? You causing trouble today? Let me listen. Yeah, he's clotted. She's clotted. You ever been to the Access Center before? Well, I'm going to go call and set you up an appointment. Have you eaten anything this morning? Yeah, I ate breakfast. Yeah, I ate breakfast. Okay, just sit tight now. And next thing you know, they make you an appointment to go get a declot. So, a loss of bruit and thrill are key signs that the access may be clotted. A thrombosis can also cause pain in your access and surrounding areas. So it's crucial. It's crucial that a thrombectomy, I'm going to break the words down, thrombectomy, which is a declot procedure, like a lumpectomy. You get a piece of a lump removed. Same thing, thrombectomy, just getting a clot removed. So it's a procedure that's be performed as soon as possible. Because if you wait around, they, messing around, I ain't going to say the word I want to say, but they effing around and whatever. You say, hey, get me in, because you don't want to lose that access. The next thing you know, you go up to, now you got 2 accesses in one arm. Look, it is crucial that a thrombectomy clot procedure be performed as soon as possible to remove that clot. As the length of time increases before a thrombosis is resolved, the likelihood that a clot procedure will be successful decreases. Now, let me repeat that. As the length of time increases before a thrombosis, before the clot is resolved, the likelihood that a clot procedure to remove it will be successful decreases. So what that means, the longer you wait, it may not be successful. And now they got to find somewhere else to start over with their new access. And that may not be cool for a lot of people. You only may have the access for 1 year. And I said you could possibly get 5 years. That's the average use, 5 years. So because a clotted access has no flow going through it, your access is not able to be used for dialysis and may lead to catheter placement. getting this put back in. So don't lollygag around and take your time. You know, now I don't have to get stuck. No, don't do that. Go get it taken care of. Because what they're going to do is going to start guilt tripping you and getting another access placed. So another problem that could happen is, again, aneurysm, which is a localized bulging out of the fistula wall. So if you got a fistula, it's called an aneurysm. And if you have a pseudoaneurysm, that's a localized bulging out due to the breakdown of the graft material. Remember, the graft is artificial, synthetic. And when it starts breaking down because of multiple cannulations, and if you got a graft and you see a bulge, that's called a pseudoaneurysm. Not an aneurysm, but a pseudoaneurysm. An aneurysm or pseudoaneurysm is visible on the skin surface as a localized bump or bulge in the axis. Their presence can be cause for concern if the size increases or if the skin over it becomes thin and shiny. So if you have a bulging or aneurysm and it's thin and shiny, there's reasons to be concerned. Because if anybody stick there, it can completely open up or rupture, as I may say. And the last common vascular complication, we talked about, what, 3 so far? 4, stenosis, thrombosis, aneurysms, pseudoaneurysms, and the last common vascular or access complication is an infection, the most serious one, I believe. Infection, presence of bacteria. The presence of bacteria in the vascular access or bloodstream. And be like, how can I get bacteria in my graft or fistula? This needle, and now arm is not clean and germs on the surface, and the needle goes through, the germs can follow through. Remember to always pay careful attention to your general health. No doubt, the presence of fever or chills is a sign of potential infection. So you should know your baseline health. If you're dealing with dialysis and you got a catheter or a fistula or a graft, you should know your baseline health. Because the presence of fever or chills is a sign of a potential infection. And let me tell you, an infection can also cause changes in the appearance or feel of your access. You got redness, drainage, swelling, localized pain at your access site can be a sign of an infection. And this goes for catheters too. And if you discover this, notify your kidney doctor and or the staff if you detect any changes in your access right away. Don't hesitate. Report signs of thrombosis or clot or infection immediately. Also, seek immediate medical attention for uncontrolled bleeding from aneurysms or cannulation sites where we stick you. Apply and hold pressure over the bleeding sites. Now, if you have a fistula or a graft and you're concerned, be at home, that you may start bleeding, you can always reach out to Steve, the kidney nurse, and get your very own HELP, which stands for Home Emergency Lifeline Kit. Now, you don't use this just to be using this. This is like what they call a bug out bag. When people say, I got a bug out bag when the apocalypse come or when we got to leave, I got the bag already packed and we can bug out. No, this is for if you start bleeding due to a rupture or your site starts to bleed at home uncontrollably, you don't have to be running around, blood spurting all over the place trying to grab a white towel. You know that you got your HELP kit right there in your bedroom drawer or on your table, wherever you put it. You go right to it, and you have your caregiver, whatever, put on the gloves, tear open the gauze that comes with it, and apply pressure over the site. And if you need to put a tourniquet to control the bleeding until you get direct pressure, it has a tourniquet. Then you put your short seal after it's stopped to make sure that it's sealed. And then after that, add your piece of tape, well, not tape, but pressure dressing. So if you're interested in the HELP, you got to access, go to www.stevethekidneynurse.com. So as we wind down, let me go to the website on the running across where you obtain the HELP Home Emergency Lifeline Kit from www.stevethekidneynurse.com. Now, as we conclude, let's talk about general rules of access care. General rules. Wait a minute. About to run out of battery. If I had an assistant, they could do all that for me. I wouldn't have to break character or whatever. But let's talk about general rules of access care. And if you just joining, thanks for joining. I'm your host, Steve Belcher. You're listening to or you're watching Kidney Hub East Africa. Okay? And we're talking about how to care for your dialysis access. So, some general rules of access care. For fistulas or graft, keep the skin over your access site clean. 2, avoid sleeping on your access arm. 3, protect your arm from injury. 4, do not allow blood to be drawn, IVs to be inserted. What I mean by IVs is they got to hang some some fluid to give you or whatever. Don't let them hang that in your access or your arm, okay? Also, don't let them take blood pressure in that arm where your access is as well. Wear loose clothing. So, when you go to dialysis and you got on something that got on like elastic or closed sleeve, and we ask, say your access is up here, and we try to ask you to roll up your sleeve, and it comes right here, it's real tight, and we can't get to it, you should be wearing something really loose. Especially when you go to dialysis and your access is up here, and wear like a loose fitting shirt so we can get all the way up and not be impeded, this, squeezing the arm and we can't get to the access. If you got a catheter, if you got a hemodialysis catheter, keep your dressing dry and intact. We're talking about the dialysis dressing that's placed over the access. Keep it dry and on. What I mean by intact, not letting it come off. Again, when you go to dialysis, you should be wearing a shirt where we can get access to properly clean the area without any impediment from your shirt. That's why we say wear cut, V-cut, or button-down shirt. Do not use sharp instruments such as scissors near your catheter. Do not. You don't want to use any type of scissors near this, because these are the things that's coming out of the skin. If somebody cut this or whatever, you can't replace one of these. They got to pull the whole catheter and replace it. Also, do not use your catheter for anything other than dialysis. And this is as we end the role of the dialysis caregiver. This is what they should know, and you're going to know this too if you're dealing with dialysis or you go. Your dialysis caregiver should wash their hands and change their gloves before caring for you. They should look, feel, and listen to your access before every treatment. Before putting that needle, they should be doing the look, listen, and feel. They should always clean the skin over your access well before needle placement. They should be rotating needle placement sites to prevent breakdown of vessel or graft material. The caregiver should avoid sticking aneurysms or pseudoaneurysms if possible. Those are those bulging bumps. The caregiver should teach you, when possible, to properly hold pressure to your access site when needles are removed after your treatment. The caregiver should check catheter exit site for signs and symptoms of infection prior to start of your dialysis treatment. And last but not least, they should wear a mask when opening caps, when they opening these caps. And you should too. When they opening these caps to put the syringes on, they should be having the mask on, covering the nose. Just like this. When they open these caps up and put the syringes on. And trust me, you should definitely be taking an active role in your dialysis treatment. You should be taking an active role, because if you don't know something, that shouldn't be an excuse. Like, I don't know. If asked the question. Let's see. Fistula is a first choice. Let's talk about things used to combat pain because of the. Yeah, what they use is something called Emula cream, which is a cream that they write a prescription for. Or you can use a tattoo cream that some kidney warriors use. They got a spray that freezes the area. Back in the day, we used to use lidocaine, where we stuck you with a needle, small gauge needle, and numbed it right there with lidocaine. A lot of companies, I haven't seen them use lidocaine in a while. They may still use it overseas, East Africa, I'm not sure. So with that being said, we done went over 30 minutes over our broadcast, and I could not stop without going over the complete information for our brothers and sisters over in East Africa of preserving your vascular access for hemodialysis. With that being said, I'd like to thank the other host, the kidney ambassador, Moses Kennedy, live from Nairobi. Unfortunately, he had internet connection stability issues. And we got to figure a way as we move forward how to deal with these pending issues out of Kenya. So with that being said, thank you guys for watching. We appreciate you. Like, share our pages, the FIGO Initiative on Facebook, Steve the Kidney Nurse, Facebook, YouTube, and TikTok. And have a great week if you go to dialysis, Kidney Warriors. Again, know what's going on with your treatment. Know what's going on. Know what your blood flow rate is. Know what your baseline arterial venous pressures are. Know what size needles you use. Okay, because again, the vascular access is one of the most critical elements of successful dialysis care. Thank you guys for watching. God bless and have a great week.